Yeah, I'm very much into media, and I'm reminded about the story that hit the media last month. The National Obesity Forum published about fat versus carbohydrates. Fat is good, carbohydrates is bad. And Public Health of England responded back to the National Obesity Forum of being premature and irresponsible to publish something like that without being peer-reviewed. As healthcare professionals, we have a serious duty to provide an unambiguous and unmistakable message toward the public. The public needs to know. Let me introduce myself. My name is Hala Jawad, and I'm a practice pharmacist within the IMH group. As well, I have a background of community pharmacist, and I'm an RPS moderator for Public Health Network, and I have an interest in patient-centered care, and I'm a prolific tweeter as well. I graduated from the University of Brighton, where I spent 4 lovely years, and my final year project was about motivational factors affecting pharmacists during, before, and after becoming a pharmacist. And probably there will be a publication soon for that. Medicine optimization. Medicine optimization and medicine management are 2 different terms, but they work together. Medicine optimization, we're talking about the patient's outcome, whereas medicine management, we're talking about the financial cost. When we combine these 2 terms, we'll have the science of pharmacoeconomics. That means the amount of healthcare we get per pound we spend is measured in quality, which is the quality of life cells. This slide behind me, this one over here, symbolizes the fact that £300 million is spent a year on waste. So let me just unpick this number, 300 million a year. And half of that we can save, 150, amazing, 150 million can be saved. And what we can do in 150 million, we can give that money to hospitals, to pharmacies, to GPs, you name it. Another example, approximately 6.5% of all hospital admissions have been attributed to or associated with adverse drug reactions. And 2/3 of that is preventable. Yeah, it's me again. I'm probably going to talk about community pharmacy and how we can, as community pharmacists, work toward medicine optimization. First of all, advanced services, medicine use reviews, and NMS, new medicine services. As pharmacists, we do reviews all the time with the patients to see if they are adhering, not adhering, happy with the medication, any problems. And I was working in a GP practice the other day, and I see an amazing referral, from a pharmacist in a community. And we see what's the problem. It's like the pharmacist is the winner, the GP is the winner, and the patient is the winner. So all of us are winner over here while the medicine use review service. And of course, when we talk to the patient, we have their consent if you want to share any information and move things forward. OTC, over the counter, as well, how many patients come to see a pharmacist every day? We're always there to give advice, we're always there to help, we're always there to see if there's any medication they're taking, they need any information. As well, the whole staff will be trained to do that. Then we have intervention. As pharmacists, we always use our professional judgment to make sure that the patient is safe, to prevent any harm against that patient. Advice on prescribed medicine, we're always there to advise and give advice about their medication. Do they need help? Are they all right? So we're always there to help the patients in the community. Repeat dispensing. As well, we have the repeat dispensing. By doing the repeat dispensing, we're there to see if that patient is complying to medication. Are they every single month to tweak up their prescription? Do they have any problems? So we're always there to help as much as we can. As well, reduce waste. So especially the vulnerable people that are sitting at home, we have delivery service. We deliver their medication to their home to make sure they are safe and they have everything they need. And then of course, signposting patient to local groups or to patient groups to make sure they are supported as well, because those patients need support and we're there to help them and support them as much as we can. And as well, this is a good one. The last one is to have a safety management system. Recently, you might have seen that in the news where unfortunately a lady passed away because she was given oral meconazole and she was on warfarin. And that became a severe interaction and started to be published all over the media to make those people aware that there is a severe interaction between oral mepenazole and what does a GP practice pharmacist does on a daily basis. I mean, as a practice pharmacist, we do repeat prescriptions, authorizing, reauthorizing, medicine management, audits. As well, we get involved in reviews with patients, long-term conditions, polypharmacy. That's the role of the pharmacist in a GP practice. We're always there to be another hand. We look at as well like documents, blood results, so all of that stuff. We're there always to give a hand to the GP practice. We work together to give them more power to name medication, anticoagulation, asthma, hypertension, with all those principles in an example by using asthma. So a patient came to me having asthma. I have to understand at the beginning the patient. Is the asthma affecting the patient? Is the patient able to do the activities they can? Is the personalized asthma action plan in place? So we're just trying to feel what the patient is feeling, the experience, how they feel, are they happy with what they've got? Principle 2, evidence-based choice of medicine. So what we do normally, we follow either the SIGN or the BTS guidelines. So asthma can get better and it can get worse. So if the asthma was worse, now we go up the scale. If the asthma is better, we go down the scale. So we have to see how that patient is doing. So we follow the guidelines to see if that patient is happy with what they've got, see they improved, they went worse. So just finding out what the patient is doing. Principle 3, ensure the medicine is used as safe as possible. So by doing that, basically we have either the asthma control test, where we do it. If it's a green one, that means the patient is controlling their asthma. If it's amber, there might be some problems there. And if it's red, that means the patient is not, their asthma is not controlled. So the thing is, how many people come to us with asthma and we feel maybe they're not happy about the inhaler, they don't like that inhaler, maybe they're not happy with the technique. We try to do in-check device to see if that technique is good or not. And there's too many issues there to look at. As well, we have these 3 questions from the Royal College of Physicians, which are amazing as well. They're there to help the patient to make sure that the asthma is controlled. And the 4th principle, we're trying to combine all of these principles to make sure, is the patient fine? Is they out of hospital? Are they taking their medication? How many of the reliever they're taking? Are they fine? So, for example, if a patient is all the time asking for salbutamol, that means there's something wrong there. Every month you need 2 or 3. That means like, you have to highlight an issue there. So this one, I liked it because it had been from the PSMC, and I love this one. There's some medication have to be prescribed. It's better to be prescribed by brands. And for reason, for example, it's either about the neurotherapeutic index or because, for example, inhalers is a good one. So if inhaler, dry powder inhaler, what we're doing with the dry powder inhaler, if a patient is used to an inhaler and they take it, that means they're used to it. We can't give them the other day like they go to the pharmacy and pick up another brand. If they're used to this inhaler, it's better to stand to one brand because it might change the patient, and we're trying to keep adherence as much as they can. So aldosterone, nifedipine, you name it. So there's medication, it's preferably always, and that's, by the way, that's the reference. It's always preferable to be on brand names. That's some more examples. Let's have a little bit more examples over there. Beclomethasone. The MOHRA has advised that CFC-free beclomethasone inhaler should be prescribed by brand name. And the reason is because it might be different particle size, it might be different inhaler, so it's always preferable to prescribe it by the brand. We sit with the patient and see what the patient wants. So that's the aim of that. Or lithium as well. Lithium is like, we have to be very, very careful with lithium. People can end up in hospitals if they didn't have the brand is different or something. So we have to make aware of a few bits and pieces, anti-epileptic drugs. So these few bits we have to be aware of if we change the preparation that might affect the patients as well. So patient-centered care, I mean we've seen that probably in loads of slides. The aim is always, always, always to make sure that we're giving there a patient-centered care. Seeing the patient's experience, safe, effective, medicine optimization, we're all aiming towards a patient-centered care. As well from the CCG Northwest, sorry. Many drugs which are beneficial and may cause harm more than benefit. So that's why we're always aiming there to make sure that the patient is safe. We're just now reaching towards the end. Thank you for listening. I just put some of the useful websites where I use, so these are the links. And I'd like to thank you very much. I'm happy if you'd like to follow me on Twitter. That's my handle. As well, I have an active Facebook page, PHARMACIST UK, and that's my email as well. If you'd like to share anything or try to be in touch, I'm more than happy. And I would like to hand the floor back to questions or any comments. Thank you very much.